This is part B of respiratory system.
So we're going to start talking about respiratory physiology and talk about the mechanics of breathing here. So when we talk about pulmonary ventilation, which is basically breathing, there are two phases to that. Inspiration, which is when the gases flow into the lungs, and expiration is when the gases exit the lungs. So when we talk about what causes us to breathe, what causes us to breathe are pressure differences. So if you remember from Bio 210 when we talk about diffusion and we talked about molecules moving from an area of high concentration to an area of low concentration. Well, pressure works the same way. So molecules move from an area of high pressure to an area of low pressure. So that's what's the driving force behind you and I inhaling and exhaling are these pressure changes. So let's talk about how that happens. So atmospheric pressure is the pressure that's exerted by the air surrounding the body. And we measure that at 1 atmosphere or 760 millimeters of mercury at sea level, which we are right here. All right. So the world around us, whether we're in a building or we're in our car or we're at home or outside, is 760 millimeters of mercury, and that's a standard. It's always the same. So we're going to be comparing against that all of the time. And what we're going to be comparing is the pressure in the lungs. When the pressure in the lungs is higher than 760, air is going to go from the lungs out. When the pressure in the lungs is lower than 760, then the air is going to go from the outside in. All right, so respiratory pressures are always described relative to this atmospheric pressure. Negative respiratory pressure is less than the atmospheric pressure, positive is greater than, and zero means that the two are equal. We also have intrapulmonary pressure, which is the pressure in the alveoli, the little sacs at the lowest part of the respiratory tree. This is also referred to as intraalveolar pressure. This fluctuates when you breathe, and it always eventually equalizes to that of the atmospheric pressure. We also have the intrapleural pressure, which is the PIP, which is the pressure in the pleural cavity. This fluctuates with breathing as well. It's always a negative pressure, so it's usually about 4 millimeters less than the pressure in the alveoli. The fluid level must be kept at a minimum. So excess fluid is going to be picked up and pumped out by the lymphatic system. If fluid accumulates in the pleural cavity, then positive pressure develops and the lung collapses because it's pushing on the lung from the outside. So there's two inward forces that promote lung collapse. One is the lung's natural springiness that causes it to recoil. The lungs have a lot of elastic tissue surrounding those alveoli, and so the lungs are always trying to get smaller and smaller and smaller. They always try to assume, as they say, the smallest size. And then we have the surface tension in the alveolar fluid, and the surface tension pulls on the alveoli from the inside to help to reduce the alveolar size. There's one outward force that tends to enlarge the lungs, and that's the elasticity of the chest wall that pulls the thorax out. So a negative pressure is affected by those opposing forces, but is maintained by this strong adhesive force between the parietal and the visceral layers that are lining the thoracic cavity. The transpulmonary pressure. So this is the pressure that keeps the lung spaces open and it keeps the lungs from collapsing. So the greater the transpulmonary pressure, the larger the lungs will be. If the lungs collapse, then what's happened is you didn't have that balance anymore. So the transpulmonary pressure failed to keep the lung spaces open. So a negative intrapulmonary pressure has to be maintained to keep the lungs inflated. So this is looking at all of those different kinds of pressure, and I know that that is very, very confusing. But just realize that these different pressures are what are causing the lung to stay inflated. So they're showing you the two pleura, the parietal and the visceral, I'm over on the right hand side, and then the pleural cavity or the space. Then they show you the transpulmonary pressure, which is typically about 4 millimeters of mercury. And so the difference between 0 and negative 4 millimeters. Then you have the intrapleural, and that's where that little arrow there is, and that's about negative 4, right? So that, then you've got the intrapulmonary, which is about 0, And so all of these things balance each other out is essentially what they're saying, is that the transpulmonary and the interpleural balance one another. A lung collapse is due to a couple of different things. It can be because the bronchioles became plugged up with mucus or fluid, and that causes the alveoli to collapse, or a pneumothorax, which is air in the pleural cavity. So that can happen because of some type of penetrating stab wound in the parietal pleura, or a rupture of the visceral pleura that can just occur because, and we treat that by removing air from the chest with a chest tube. When the pleura heals, the lung is reinflated. So they're showing you with a kitchen knife, not so nice, what happens. So you have a punctured parietal pleura, like from a knife wound, a stab wound, that kind of thing. And so you see what happens there is that the pressure, if you look, follow the arrow that goes down, the pressure is no longer balanced in the lung, and so the outside pressure essentially is pushing on the lung and causes it to collapse. If you have a ruptured visceral pleura, which again can just happen, it can be spontaneous. They're showing you that little rupture area right there, and they show you what happens with the pressures there. So those are two reasons why the lung might collapse. So as I mentioned at the beginning, pulmonary ventilation is inspiration and expiration, and this is the mechanical process that depends on the volume changes in the thoracic cavity. So this is the main thing that we're talking about here in this chapter. The other ones are just, what keeps the lung inflated, that kind of thing. This is how does air move in and out. And so thinking about physics for just a second, we know that volume changes lead to pressure changes. So let's talk about pressure for just a second. Pressure is what happens when molecules collide with one another, and they collide with the side of the container. So I want you to think for just a second about if we were to take a room and put everybody in the room and blindfold them. And you guys are the molecules. And so you're walking around blindfolded, and you're going to run into each other, and you're going to run into the walls in the room, right? If I change the volume, i.e. the size of the room, and I make it smaller, you guys are going to run into each other a whole lot more, aren't you? And so that's the idea, is that when we change the volume, it changes the pressure, because it either increases or decreases the number of collisions, and that changes the pressure. All right? Pressure changes, as I mentioned, are what lead the flow of gases going in and out. So we talk about Boyle's law first. Boyle's law is the relationship between pressure and volume in a gas. So gases, when they're put in a container, and your lungs are a container, they always fill the container. If the amount of the gas is the same, the container size is reduced, the pressure increases. So what we always say is that Boyle's law represents an inverse relationship between pressure and volume. If the volume increases, the pressure goes down. So if the volume increases, that means the room got bigger and you guys aren't hitting each other as many times. But if the volume decreases, the pressure goes up. That means the room is smaller than it was before, and you guys that are walking around blindfolded are hitting each other more frequently because you're in a smaller space, a smaller volume. So it's an inverse relationship. It's the pressure that varies with the volume, not the volume that varies with the pressure. So the pressure changes because the volume changed, not the other way around. So let's talk about inspiration first. This is an active process that involves the inspiratory muscles that include the diaphragm and the external intercostals. So remember back when we were looking at muscles, and I said we were looking at the internal and external intercostals, and I said the one thing I want you to remember is that the external intercostals are involved in inspiration, and the internal intercostals are involved in expiration. They're just the opposite of what we would think. So this is going to be the inspiration. So we're talking about external intercostals. So the diaphragm. The diaphragm at rest is dome-shaped. All right. When it contracts, it flattens out. And when it flattens out, it actually increases the volume of the thoracic area. So when it is relaxed, it decreases the volume of the thoracic area. The intercostal muscles, when the external intercostals contract, the rib cage is lifted up and out. And of course, that's going to increase the volume as well. So as the thoracic volume increases, so we have the diaphragm that's flattened out, and we have the intercostal muscles that have pulled up the rib cage. We've increased the volume. We have compared to the outside world, and so we're going to see what happens. So the intrapulmonary pressure drops to about 1 millimeter of mercury. And that's enough of a change for it to cause um, the air to move in and out. So remember, the outside is always 760, so we're always comparing that. And air is always going to go from an area of high pressure to an area of low pressure. So if we increase the volume, we decrease the pressure compared to the outside world. And that decrease that we experience is only 1 millimeter of mercury. So the lungs were at 760 inside, the outside world was 760, so they were equal. We increase the volume, so we decrease the pressure, we move it down to 759, 758, right? And that's enough to cause air to rush in. Forced deep inspirations can occur during vigorous exercise or with people who have COPD. In this case, you have the accessory muscles that become involved that include those scalenes. So we had three different scalenes, the anterior, the middle, and the posterior that we looked at in Bio 210. The sternocleidomastoid and the pectoralis minor are all muscles that help to elevate and pull in more air. The erector spinae muscles, which we didn't talk about, but they're the muscles that straighten out the curve in the thoracic area. And all of these things together increase the thoracic cage size, which creates a larger pressure gradient, so more air is drawn in. So there's the picture that we're looking at there. So remember, it's only a 1 or 2 millimeter of mercury difference, but it's enough to make that air move. So when all of those events happen, the diaphragm flattens out, the external intercostals pull those rib cage muscles, pull the rib cage out. When they contract those muscles, that creates more volume, and therefore we have a lower pressure compared to the outside world, and air rushes in. So that's what it's telling you in this little. What about expiration? So quiet expiration is a passive process. The inspiratory muscles relax, the thoracic cavity volume decreases, and the lungs recoil. So the volume decrease causes the intrapulmonary pressure to increase by, again, just 1 or 2 millimeters of mercury compared to the outside world. So we go from 759 in the lungs when we're getting ready to expire, it'll go up to 761 or 759 up to 761 or 762 compared to the outside world of 760, which is what makes it move out because air goes from an area of high pressure to an area of low. Forced expiration, however, when you blow it all out, that is an active process, and it uses the oblique and the transverse abdominal muscles as well as the internal intercostals. So that's the bottom half of this picture. So talking about what happens for expiration, the diaphragm moves back up to its normal position, the rib cage falls back down, and that decreases the volume, therefore increases the pressure inside of the lungs, and that causes air to move out to the outside, or expiration. So just looking at the changes in all those different factors that happen during inspiration and expiration. What about non-respiratory air movements? So a lot of things that happen can move air in and out of our lungs besides breathing. This may modify the normal respiratory rhythm. So these are results of reflexes for the most part, but sometimes they can be voluntary. So things like coughing, sneezing, crying, laughing, hiccups, and yawns are all considered non-respiratory air movements that we're either pushing air out or we're pulling air in. All right, what are the physical factors that influence pulmonary ventilation? So there's three physical factors that we talk about that influence the ease or the how easy it is for air to move in and out and the amount of energy that's required for us to breathe. One of them is the resistance, airway resistance, meaning the tubes that are taking the air down, the alveolar surface tension, and lung compliance. So airway resistance, friction is the major non-elastic source of resistance to gas flow, just like we saw with blood flow. This is what occurs in the airways. So we're talking about the trachea, the bronchioles, and all that sort of thing. The relationship between flow and pressure and resistance. So flow is equal to a change in the pressure divided by the resistance. The change in pressure is the pressure gradient between the atmosphere and the alveoli, which is typically about 2 millimeters of mercury or less during normal quiet breathing. That's sufficient to move about 500 milliliters of air. So gas flow changes inversely with resistance. So just like we saw with blood flow, if there's more resistance, then it makes it harder for it to flow. Resistance in the respiratory tree is usually insignificant for two reasons. The diameter of the airways in the first part of the conducting zone, they're huge. So you got great big huge diameter when we talk about the trachea. And then the progressive branching as they get smaller leads to an increase in the total cross-sectional area. So when we look at all of those bronchioles and calculate the cross-sectional area for all of them together and add them together, we still have a very large total cross-sectional area. Any resistance we have usually occurs in the medium-sized bronchi. The resistance disappears at the terminal bronchioles, where the diffusion is what is driving gas movement at that point. So looking at this in the conducting zone, which is up here in the top, then there's very little resistance that's met there until we get to those medium-sized bronchioles, and then it decreases as we get to the terminal bronchioles, and then we're in the respiratory zone. There's very little resistance at all. As airway resistance rises, breathing movements become more strenuous. So severe constriction or obstruction of the bronchioles can prevent a person from being able to breathe, and it can be life-threatening. And this is what happens in an acute asthma attack, and it can stop the ventilation. Epinephrine is what dilates bronchioles, and it reduces airway resistance. So that's what we see in an allergy attack or anaphylactic shock. What an EpiPen is epinephrine, and you give that to the person, you stab them in the leg with that, and that is what allows them to open up their bronchioles and can breathe again. Alveolar surface tension is another physical factor that influences the pulmonary ventilation. So surface tension, if you remember from Bio 210, is the attraction of the liquid molecules to one another at the interface between air and water. So I always say it's kind of like the skin that's on the surface of a liquid. It's not really a skin, but those molecules that are there are just kind of holding a little bit tighter to each other, and that draws the liquid molecules closer together and reduces the contact with dissimilar gas molecules at that interface. So it resists any force that tends to increase the surface area of the liquid. Water has a really, really high surface tension. It coats the alveolar walls in a thin film, and that tends to cause the alveoli to shrink to their smallest size, in other words, to collapse. So what counteracts that is surfactant. This is your own detergent-like lipid protein complex that you make that helps to reduce the surface tension in the alveolar fluid and thereby preventing the alveoli from collapsing. This is produced by the type 2 alveolar cells. If you don't have enough surfactant, that can create a problem. And that's exactly what you see in premature infants. And it causes a condition called infant respiratory distress syndrome. And it causes the collapse of the alveoli after each breath. So if you've ever seen a preemie trying to breathe, when you see that preemie, it's almost painful to watch. Their little chest just basically collapses every single time, and they use so much energy trying just to breathe that they're not using any energy to grow. So a lot of times in premature infants, they ventilate them in the beginning. They can breathe on their own, but the energy they use to do that, they're going to consume all of their energy. They're already premature, they're already undersized, and so they need their energy to grow and not just to breathe. And so that's why they typically put a premature baby on a ventilator like that, so that it can ease up that process and they can use their calories to grow. The treatment for this is spraying natural or synthetic surfactant into the newborn's air passages, but that takes a couple of days to work. And so they may be on that ventilator for a day or two. Positive pressure devices, that's what I'm talking about with the ventilator, help to keep the alveoli open between breaths. In severe cases, they may require mechanical ventilation. Survivors of mechanical ventilation often develop a condition called bronchopulmonal dysplasia, which can create chronic childhood lung disease. So they don't want to leave them on that vent any longer than they possibly have to, but often they'll do it for a day or so just to get that the synthetic or natural surfactant to get to working. They can also give mom prednisone if they know that the baby's going to come early. They can give mom prednisone, and that helps to speed up the production of surfactant. So another factor that influences pulmonary ventilation is lung compliance. Essentially, this is the stretchiness of your lung. So it's a measure of change in the lung volume that occurs with each given change in the transpulmonary pressure. Again, it's a measure of how stretchy your lungs are. So normally this is a pretty high number. Your lung compliance is high because lung tissue is very stretchy or distendable, and then you have that surfactant, which decreases the alveolar surface tension and allows the lung to be more stretchy. A high lung compliance means it's easier to expand your lung. So they can write this mathematically. Don't worry about that particular part. What we want to know is what changes the compliance or what is diminishing it when you have fibrosis in the lungs or non-elastic scar tissue, because if your lung tissue is damaged in some way and it's replaced with scar tissue, if you're not producing enough surfactant, or if you have decreased flexibility in the thoracic cage, typically due to arthritis. The total compliance of the respiratory system is also influenced by the stretchiness of the thoracic wall, which is decreased by deformities. Sometimes individuals have deformities in their the bony thorax, their rib cage, ossification of the costal cartilages, and that's what's connecting your ribs to your sternum. Those are the costal cartilages. They become bone-like, and so the rib cage doesn't move as easily, and then paralysis of the intercostal muscles. How about assessing ventilation? So there's several different respiratory volumes that we want to use to assess the status of our patient. Respiratory volumes are combined, and we calculate respiratory capacity. So this is what a respiratory therapist does. This gives us information on the status of the respiratory system. So the volumes and the capacities are usually abnormal in people who have some type of pulmonary disorders, and they use a device called a spirometer to do this. So it's a very cumbersome clinical tool that we can use. Nowadays, we have a really cool one that's electronic that's a lot easier to use. So here's some respiratory volume. So you want to make sure you know what these are. Tidal flashcards are really good for this. So the first one is tidal volume, and the initials for this are TV. This is the normal amount of air that a person moves in and out of their lungs with each breath. So this is typically on average between about 500 milliliters. So I always say, think about a 2-liter Coke bottle. So it's about a fourth of a 2-liter Coke bottle. All right. Inspiratory reserve volume, or your IRV, this is the amount of air that can be inspired forcibly beyond the tidal volume. So you take a breath, and then you take a deep breath right behind that. And so the inspiratory reserve volume is anywhere between 2,100 and 3,200 milliliters based on whether you're male or female. The expiratory reserve volume, or the ERV, is the amount of air that can be forcibly expelled from the lungs. So you tell the patient to breathe in, take a super deep breath, and then you tell them to push it all out. All right. And so that's about from 1,000 to 1,200 milliliters. Then the residual volume. The residual volume is the amount of air that always remains in the lung, no matter how much you push out. So this is what's necessary to keep the alveoli open. Respiratory capacities are when we combine two or more of those respiratory volumes. So your inspiratory capacity is your tidal volume plus your inspiratory reserve volume. Your functional residual capacity, or your FRC, is the sum of your residual volume plus your ERV. Your vital capacity, which is the sum of your tidal volume plus your IRV plus your ERV, and your total lung capacity, or TLC, is the sum of all the lung volumes combined, TV plus IRV plus ERV plus RV. And that's what the respiratory therapist is typically looking at. She has to get the measurements, and then she can figure the capacity. And so there's a chart helping you see this for a male. Again, the numbers are going to be different for males and females. And that's what they're showing you here. So the tidal volume is pretty much the same, but you can see there's big differences in the IRV, there's differences in the ERV, there's difference in a slight difference in the residual volume. But when we start looking at the capacities, you see some significant difference, and it's because males have bigger bodies, they have bigger lung capacity than do. We have bigger lungs, they have bigger chests, all those kinds of things. So the only one of the measurements that I suggest that you know is the 500 milliliters for the tidal volume. The rest of them, worry less about knowing what the actual volume is, but make sure you know what the definition is of each of those and how they're calculated. So for instance, total lung capacity is, TV plus IRV plus ERV plus RV. So make sure you know what the definition of it is, and and how it's calculated, and what the abbreviation is, because you'll never see that all written out. Then we have to also consider what's called the anatomical dead space. So when air goes in, not all of it gets to the exchange surfaces. Some of it stays in the pathway. So it was like if I opened up your head and I poured in Skittles down your respiratory tubes, not all of them would get all the way down to the alveoli, right? Some of them would stay in your trachea and places like that. And so that's what's considered the anatomical dead space. So basically this is the air that remains in the passageways. So out of 500 milliliters in your tidal volume, it's roughly 150 milliliters. This is what you're breathing out in rescue breathing. This is why rescue breathing can actually work. If all of the air went down to your lungs for exchange, if you were using rescue breathing, you would be breathing nothing but carbon dioxide into your patient. Alveolar dead space is the space occupied by any non-functional alveoli. Alveoli die. They collapse. They become obstructed. So you have those to consider. So you have the total dead space, which is the sum or the adding of the anatomical and the alveolar dead space together. Pulmonary function tests help us distinguish between different kinds of diseases. So when we're looking at obstructive pulmonary disease, you have increased airway resistance. So some examples of this would be like bronchitis. So your total lung capacity, your functional reserve capacity, and your reserve volume or residual volume may increase because of hyperinflation of the lungs. If you have a restrictive disease, things like tuberculosis or exposure to some type of an environmental agent that causes fibrosis, you have a reduced total lung capacity. So your vital capacity, total lung capacity, functional residual capacity, and reserve volume are going to decline because of lung expansion is compromised. So they can do these tests and they can differentiate between an obstructive pulmonary disease and a restrictive pulmonary disease. Pulmonary tests can also measure the rate of gas movement. So forced vital capacity, or the FVC, is the amount of gas that's forcibly expelled after taking a deep breath, and forced expiratory volume, or FEV, is the amount of gas that's expelled during a specific time period of the FVC. All right. So typically, you're measuring the amount of air that's expelled in the first second. So a healthy person can expel approximately 80% of the FVC in the first second. If they have an obstructive disease, they exhale less than 80% in the first second, whereas those that have a restrictive disease exhale 80% or more, or even more, with reduced FVC. So again, they can look at those to try to determine the difference between a restrictive and an obstructive disease. Also measure minute ventilation. This is the amount of gas that flows into and out of the respiratory tract in 1 minute. At normal rest, we're talking about 6 liters per minute. So 3 2-liter Coke bottles at rest per minute. If we start exercising, that can go up to 200 liters per minute. This is only a rough estimate of respiratory efficiency. They can look at the alveolar ventilation rate. So this is the flow of gases into and out of the alveoli during a particular time. And obviously this is a better indicator. Minute ventilation doesn't take into account what happens down at the alveoli. So you can be bringing air in, bringing air out, and it may not be getting down to the alveoli. So we really want to look at what's happening at the alveoli because that's the site of exchange. The alveolar ventilation rate takes into account the amount of dead space, the tidal volume, and the rate of breathing, and they show you how that is calculated. It's the number of breaths times the tidal volume. And so that's how they calculate AVR. Dead space in an individual is normally consistent, so pretty much everybody has the same dead space. The AVR is affected mostly by tidal volume and frequency. If you have a significant increase in the AVR, that's brought about by an increase in the tidal volume rather than the frequency. Rapid shallow breathing can actually decrease your alveolar ventilation rate. So taking a look here at 3 different hypothetical patients. Patient 1 has normal rate and depth of breathing. So they show you with the dead space, and you see that that's the same in all 3 patients. So that is a standard for the most part, is 150 milliliters. It shows you what the tidal volume is in your normal patient, your respiratory rate, what their minute volume is, their alveolar ventilation rate is, and their percent effective ventilation, which is 70%. Looking at patient 2, who's breathing slow and deeply, their tidal volume is 1,000 milliliters. Their respiratory rate is 10 breaths per minute. Their minute volume is the same, or their minute ventilation is the same. Their alveolar ventilation is higher and their effective ventilation rate is 85%. And then look at patient number 3 that's got rapid shallow breathing, 250 milliliters with their tidal volume. So they're taking in half the normal amount, 40 breaths per minute because they're breathing twice as fast. And look what happens at their percent effective ventilation, only 40%. So just to compare how those are different from one another. So let's talk about gas exchange for just a few minutes. So gas exchange is what happens between the lungs and the blood and the tissues. So we talked about gas exchange when we talked about the capillaries, and we're dealing with capillaries here. Capillaries are surrounding the alveoli, and we're dealing with capillaries down at the tissues. That's where we're exchanging. So external respiration is what happens between the lungs and the blood. So this is what happens at the lungs with the little capillaries that are all over, surrounded, clinging to the outside of the alveoli. Internal respiration is what happens when the gases diffuse from the blood into the tissues some distance away from the lungs. Both of these processes are subject to basic properties of gases and to the composition of the alveolar gas. So the first one we talked about Boyle's law already, and Boyle's law was an inverse relationship between pressure and volume, and that explains breathing in and out. Dalton's law of partial pressures talks about gases as the mixture of gases that we breathe in. So air is not 100% oxygen, obviously. It's made of a lot of different gases, and those different gases each are going to contribute some part of the total pressure of 760 millimeters that we talk about. So the partial pressure is the pressure exerted by each gas in that mixture, and that's directly proportional to the percentage in the mixture. So here's how you look at this. The total atmospheric pressure we've already declared as a constant at 760 millimeters of mercury. Unless you go up way high on a mountain or you go scuba diving way, way deep, it's going to be 760. All right, so 760 millimeters of mercury is our standard. Nitrogen makes up roughly 78.6%. Therefore, the partial pressure of the nitrogen. So what is the nitrogen contributing to the 760? This is how we calculate that. So we have 0.786, because that's our 78.6, times 760 millimeters of mercury, or 597 of the 760 millimeters of mercury is due to nitrogen when we talk about that. Oxygen, on the other hand, makes up 20.9% of air. So when we calculate it out, we convert the 20.9% to a decimal, so 0.209 times 760. So oxygen only contributes 159 millimeters of mercury to the total of 760. So that's what they mean by partial pressures. Each gas in the air is contributing some part to that 760, and it's based on the percentage of that particular gas found in the air. Also contains a 0.04% carbon dioxide, 0.5% water vapor, and some insignificant amounts of other gases. At high altitudes, the partial pressure declines, but at lower altitudes underwater, partial pressure increases significantly. That's why scuba divers have to be really, really careful when they're coming up from deep dives. They have to stop and do what's called a check at that point and allow for the nitrogen and the different gases in their body to get back to where they're supposed to be before they come up to the surface of the air. Otherwise, they can get decompression illness. So I don't know why this one's in here again, but here is that chart once again with your patient. Now we got to talk about Henry's law. All right, so Henry's law for each gas mixture is what we talk about with gas mixtures in context with liquids. So each gas will dissolve into the liquid in proportion to its partial pressure. So at equilibrium, the partial pressure in the two phases will be equal to one another. The amount of each gas that will dissolve depends on the solubility. So for instance, carbon dioxide is 20 times more soluble in water than oxygen is, and nitrogen has very low solubility, and the temperature. As the temperature of the liquid rises, the solubility decreases. So Henry's law, number one, explains why when you open a soda, anything carbonated, it makes that noise, right? That's Henry's law that was keeping those bubbles pushed into the gas into the liquid. And then when you take the pressure off the liquid by opening the container, it allows that gas to start to leave the liquid. It's also how we use hyperbaric chambers. So I don't believe that there is a hyperbaric chamber here, but there are several of them in Charleston. Hyperbaric chambers have several uses. One, of course, is for someone who scuba dives and comes up too quickly and gets what they call the bends or decompression illness. But hyperbaric chambers also are really important for wound healing. And so they use them a lot with diabetics who have wounds that won't heal. They use them for burn patients. So breathing oxygen gas at 2 atmospheres is not a problem for a short period of time. However, oxygen toxicity can develop rapidly when the partial pressure of oxygen is greater than 2.5 or 3 atmospheres. So excessively high oxygen concentrations generate a huge amount of those harmful free radicals. If you remember, free radicals are those molecules, oxygen molecules that are missing an electron, so they go out and they steal them from other electrons, and it turns into like this chain reaction. And this can result in a central nervous system disturbance, coma, or even. So let's look at the alveolar gas. So alveoli are going to have more carbon dioxide and water vapor than the normal air we breathe, because this is where the gas exchange is happening. So the exchange at the lungs is when the oxygen diffuses out of the lungs and into the blood, and the carbon dioxide diffuses out of the blood and into the lungs, and that's happening right at the alveoli or the capillaries surrounding the alveoli. If it also is different in the alveoli as far as the carbon dioxide and water vapor amounts, because of humidification of the air as it's passing through the conducting passageways. That's what adds the water vapor. The mixing of the alveolar gas with each breath. Every time you breathe in and you breathe out, not all air leaves every time. So there's new air that's mixing with air that was left in the passageways between breaths in that anatomical dead space. So it's just showing you the comparison of the partial gas pressures and the percentages in the atmosphere and the alveoli. So external respiration. This is pulmonary gas exchange. This is what's happening at the respiratory surfaces. So the exchange is fluid influenced by the partial pressure gradients and gas solubility. It's also influenced by the thickness and the surface area of the respiratory membrane, and by ventilation perfusion coupling, which is the idea that we're matching the alveolar ventilation with the pulmonary blood perfusion. So what's being exhaled and what is being inhaled, all of that's supposed to match. So let's talk about the partial pressure gradients and gas solubilities. So the steep partial pressure gradient for oxygen exists between the blood and the lungs. So there is more oxygen in the blood than in the lungs than there is in the blood. All right. So the venous blood, the amount of oxygen is about 40 milligrams. The alveolar oxygen is about 104 milligrams, and so that's going to push the oxygen out of the lungs and into the blood. All right. So equilibrium is reached across that respiratory membrane really, really quickly in about a fraction of a second, a fourth of a second, but it takes the red blood cell another 3/4 of a second to travel from the start to the end of the pulmonary capillary. And that's going to ensure that we have adequate oxygenation even if the blood flow increases by 3%. The partial pressure gradient for carbon dioxide is less steep. In the venous blood, it's about 45 millimeters of mercury. In the alveolar and the alveoli, it's about 40 millimeters of mercury. So even though that gradient is not especially steep, carbon dioxide still diffuses in equal amounts with the oxygen, because carbon dioxide is 20% more soluble in the blood plasma and alveolar fluid than oxygen is. And so they're showing you some pictures of what that looks like. So in the different vessels and the different structures, you can see the differences between the amounts of oxygen and carbon dioxide that you have in different tissues. This is just showing you what happens at the capillary. So remember that the blood has to flow through the capillary, and as it's flowing through the capillary, it's exchanging along the way, and so it takes a certain amount of time, as they say 0.75 or 3/4 of a second, for the blood to go from one end of the capillary to the other, from the arterial side to the venous side. The thickness and surface of the respiratory membrane, the surface area. So the respiratory membrane is typically very, very thin, 0.5 to 1 micrometer thick, so teeny, teeny, teeny thin. It has a large surface area in the alveoli. It has the 40% more surface area than the surface area of the skin. So effective thickness of the respiratory membrane increases dramatically if the lungs become waterlogged or full of fluids. That's what's seen in pneumonia or in left heart failure. That 3/4 of a second that the red blood cell spends in transit may not be enough time for gas exchange to happen. And so what ends up is you have oxygen deprivation in the tissues. All right, ventilation, perfusion, coupling. So perfusion is about blood. It's the blood flow that reaches the alveoli, all right, in the capillaries. Ventilation is the amount of gas that reaches the alveoli. And so what we hope for is that those two things are matched. So the amount of gas that's in the alveoli and that there's enough blood to be able to carry that gas. So that's the whole idea between those two things being matched. Both are controlled by local autoregulatory mechanisms. The oxygen controls perfusion by changing the arteriole diameter because that's the blood side, and then the carbon dioxide controls ventilation by changing the diameter of the bronchioles because that's the respiratory side. So what is the influence of the local pressure of oxygen on perfusion? So when you have changes in the pressure of oxygen in the alveoli, that causes changes in the diameters of the arterioles. So when your alveolar oxygen is high, the arterioles dilate, and when the alveolar oxygen is low, they constrict. That directs the blood to go to the alveoli where the oxygen is high, so the blood can pick up more oxygen. The opposite mechanism is seen in the systemic arterioles that dilate when the oxygen is low and constrict when it's high. What is the influence of the pressure of carbon dioxide on perfusion? So there are changes in the carbon dioxide pressure in the alveoli that cause changes in the diameter of the bronchioles. So when the alveolar carbon dioxide is high, the bronchioles dilate, and when it's low, they constrict. And so this allows us to get rid of the carbon dioxide more rapidly. Remember that carbon dioxide is an acid, and it's going to drop the pH of the blood real dramatically if we don't get rid of it. So we balance ventilation and perfusion. So we have changing diameters in the local arterioles and the bronchioles, and those synchronize this ventilation perfusion. It's never balanced for all of the alveoli because you have regional variations because of gravity on the blood, airflow, those kinds of things. And occasionally alveolar ducts are plugged with mucus or they have damage to them and they cause unventilated areas. So it's talking about this slide's just showing you ventilation with less perfusion. So you've got less blood, basically less oxygen in the blood, and they show you how the compensation happens for that, and then what happens when you have when the ventilation is greater than the perfusion. Internal respiration is what happens between the capillaries and the tissue. So external was what was happening up at the lungs. Now we're going to transport those gases, that oxygen, down to the tissues, and we're going to drop the oxygen off at the tissue and pick up the carbon dioxide, and that's going to be internal respiration. So the partial pressures and the diffusion gradients are obviously reversed compared to external respiration. So when the oxygen level in the tissues is lower than the arterial blood, we expect that. That's what we should have. It's why we're taking oxygen down to the tissues, is there's less oxygen down there. So oxygen moves from the blood into the tissues. And then your carbon dioxide should be greater in the tissues than it is in the blood. So it's going to move from the tissues into the blood, and we're going to carry it up to the lungs and exhale it. The venous blood returning to the heart has the pressure of oxygen is about 40 millimeters of mercury, and the pressure of carbon dioxide is about 45 millimeters of mercury. And so they're showing you that picture again, looking at, where is the oxygen in this tissue? Where is the carbon dioxide? What are the percentages that we're seeing there? What is the pressures that we're seeing there? And it's helps you understand why exchanges are happening where they are.